see when you practice, when you go as doctors, you don't see these concepts. You will see patients coming. So usually it's therefore you need to know how to apply this knowledge to actual patients. That's what you have to do. So these cases are designed to highlight these issues. So first we will start with the case studies. Okay, can you see the screen?
Yes, sir, we can.
Right. Okay. So these are cases. So I sometimes I might want to stop and ask you what you think and all that. So we try to see whether we can do it as an interactive session. So we'll start. So case history number 1. A 35-year-old man presents with bilateral painless ankle swelling for 1 week. What is the differential diagnosis? Right? So this is a very common presentation, bilateral ankle swelling. So, usually when these patients come with ankle swelling, you have to think of 3 main organ systems involvement. One is cardiac, one is liver, and the other one is kidney. So any of these 3 organ involvement can give rise to edema. So that's the first thing you have to see. So when it comes to kidney, you have to think of things like nephrotic syndrome. I have already taught you these things. So then important thing is you have to check for presence of various, in the history, whether there are any signs or symptoms to suggest any of these problems. So you have to check their urine color, whether they have proteurine, whether they have got urinary symptoms, whether they have been on any nephrotoxic medications, and also whether the patient has ischemic heart disease, diabetes, hypertension, family history of renal. So these are the things that you have to look for in the history. And so patient doesn't have any of those. And on examination, there was bilateral pitting ankle edema. JVP was not raised. Lungs are clear. And blood pressure was 130/80. Nothing remarkable except the edema on the examination. So what initial investigations would you do now? Anybody? What are the things you can do now to find out why this patient has swelling? Just to make it interactive.
Urine full report.
Okay, so urine full report shows pus cells 60 to 8 per high power field, red cells 10 to 15 per high power field, protein 3 plus, serum creatinine is 0.9 and potassium is 4.1. And serum albumin comes as 25 grams per liter. 24-hour protein excretion is 4.1 grams. So what is the diagnosis? Anybody?
Nephrotic syndrome?
Yeah, that's right. So you have all the features of nephrotic syndrome in this patient. Patient has presented with edema, and there is proteinuria, 4.1 grams, which is more than 3 or 3.5 grams per day. Then she has very low albumin. Obviously, we don't know the cholesterol or the lipid levels. From ultrasound scan, so that the diagnosis is nephrotic syndrome. So the ultrasound scan shows normal size kidneys. Nothing remarkable on the ultrasound. Urine culture is also sent. Then a urine microscopy shows red cell CAS, which is also in keeping with the glomerulonephritis. And what is the diagnosis? Yes, the diagnosis is nephrotic syndrome. then what further investigations would you do? Can you tell, can any of you tell what are the other things you want to do now? Having done the basic investigations and you have now got the diagnosis of nephrotic syndrome, I told you that in any clinical presentation of a nephrotic or whatever glomerular disease, there are 3 levels of diagnosis. First level is the clinical or the syndromic diagnosis, which we have done, nephrotic syndrome. What is the next level of diagnosis? Can you remember what I taught you in the lecture on glomerular?
Etiology.
Before the etiology, there's one level before that. What is that?
Histology.
Yeah, so that's the pathological diagnosis, right? So histological diagnosis or the pathological, histology is normal thing, whereas pathology is abnormal. So this patient is probably has a pathology. So the pathological diagnosis is the next level. So how do you get to the pathological diagnosis? How do you get to the pathological diagnosis?
Renal biopsy?
Yes, so you do a renal biopsy, right? So so before that, yeah, as somebody mentioned, etiological diagnosis also comes into play. So we generally renal biopsy is the next one that we will do, but obviously, biopsy doesn't happen immediately. You have to prepare somebody for biopsies, and then biopsy is done. Then you need to send it for histological evaluation, and that might take time. So until all this happens, you also have to think of the etiological factors. So what are the causes for nephrotic syndrome. So there are infective causes, there are autoimmune connective tissue disorders, drugs. So these are some of the tests that you would want to do while you wait for the biopsy findings. And so this is the biopsy finding. You don't get to see this actually, but this is just for your information. So this is a normal glomerulus on the left side, and on the right side is the biopsy of this particular patient. Do you think there's a problem in the biopsy? Is it normal? Is it the same as the left side normal glomerulus, or is there anything abnormal? What is the impression you get? There is some abnormalities, right? Here it's very clear. You see these capillary loops, which are very patent, lots of capillary loops. And you have this mesangium, which is quite little mesangium with few cells. But on this side, you see that the capillary loops are much less than here. You see a capillary loop here, there, but they are not so open. So there's some capillary luminal narrowing. Plus the mesangium is also expanded, more pinkish material here. So that is a mesangium, and more cells. These nuclei denote cells. So there are more cells here. So it's like a mesangial hypercellularity and mesangial expansion. So this is the clinical description is mesangioproliferative type of glomerulonephritis. So when you do the immunofluorescence, you see that it stands for IgA. So what's the diagnosis?
IgA nephropathy.
Yes, IgA nephropathy. So that's the diagnosis. So so this person has got IgA nephropathy causing nephrotic syndrome. So this is the first case. So that's how you work out. So you initially get the history examination and come to a initial basic investigations and come to a clinical diagnosis. So in this case, it was nephrotic syndrome. Then you do the biopsy. So in the biopsy, you look at the pathological diagnosis, which is just a mesangioproliferative kind of glomerulonephritis based on the description on the light microscopy. And then you have to think of the etiology. So in this case, it was IgA nephropathy. Okay, so case history number 2. A 56-year-old male presents with reduced urine output for 1 day. He has developed a sore throat 1 week back and was started on erythromycin 500 milligrams 6 hourly. He's diagnosed patient with type 2 diabetes for 10 years and ischemic heart disease for 2 years. Medications include aspirin, ISMN, atenolol, enalapril, metformin, and atorvastatin. Okay. So the problem is he has come with reduced urine output and he had a sore throat a week ago. On examination, he's afebrile and the sore throat was not inflamed. Edema was not there. There were no skin rashes. Blood pressure was high, 140 over 100, but we know he's a hypertensive patient. JVP not raised, chest was clear. What are the differential diagnoses here? Anybody? Somebody coming with reduced urine output, history of sore throat a week ago. Blood pressure is slightly on the high side. What are the possibilities? Now you have to apply your knowledge from the lectures.
Acute kidney injury?
Yes, acute kidney injury, because you know, acute kidney injury is diagnosed based on two factors. One is on elevation of serum creatinine, the other one is a drop in urine output. So clearly, this person has reduced urine output. So that's one thing you can think of, acute kidney injury. Any other differential diagnosis? So first you have to make a clinical diagnosis. That's what we are trying to do. Next, we are going to look at the pathology and the underlying etiology. So the clinical diagnosis are the ones that you need to think of, because that's how you start the diagnostic workup. So as one person said, it is possibility that this is acute kidney injury. Any other possibilities?
Nephritic syndrome.
Nephritic syndrome. Why do you say it's nephritic syndrome?
Because of the reduced urine output.
Yes, and
the elevated blood pressure.
Yes, so there are certain features that will similar to nephrotic syndrome. So these are oliguria, presence of haematuria, hypertension, and edema. So, but here there was no edema, so only blood pressure was high, but oliguria is there. So that's another possibility. So we look at the investigations. You see there is blood 3 plus, protein 1 plus, red cells 1 to 2, WBC 6 to 8, granular cast present, creatinine is elevated, creatinine is 2.1, potassium is 6.1. So there's clearly acute kidney injury, as one person suggested, and also there is evidence of some blood and protein in the urine. So maybe it could be a glomerulonephritis, we don't know. And this is the appearance of the urine. Is it normal? Clearly, it's abnormal, right? It's brownish color urine. So, and when you look at the urine sediment, you see this. What is this? Anybody wants to have a go? So it's a cast, but it's not the typical red cell cast. With red cell cast, you see red cells attached to this cast. It's more yellowish kind of a thing. This is something more, it's different. It's a more orange or brownish kind of appearance. And what do you think is the cause for this person's AKI? Anybody? So in fact, these are myoglobin casts. So this is color of myoglobin in the urine. So in fact, this patient has got statin-induced rhabdomyolysis causing myoglobinuria. So that was the diagnosis. So he has got acute kidney injury due to statins. So this patient was on a statin, And atorvastatin can cause rhabdomyolysis. And interestingly, when you look at this patient's urine dipstick, you see there's 3+ blood, but when you look at the urine full report, only 1 to 2 red cells. So clearly, this doesn't tally, because you expect to be much more red cells in the urine to account for this blood 3+. So what has caused this blood 3+ in the urine dipstick? Anybody? So you had a lecture, not a lecture, a PBL on haematuria, right? So we have a second session coming up. So in that also you would have kind of searched for this type of things, myoglobinuria, which is similar, which is a DD for haematuria. So haematuria means red cells in the urine, whereas there are other mimics like hemoglobinuria or myoglobinuria, where there are no cells in the urine, but there is myoglobin and hemoglobin. So what you check in urine dipstick for blood is actually the heme component. So red cells have the heme because hemoglobin is inside the red cell. So when you have red cells, you get blood positive. But when you also have myoglobinuria or hemoglobinuria, there also you get the heme component in myoglobin as well as in hemoglobin. So that's why even when there is no hematuria, even if you have hemoglobinuria or myoglobinuria, still the urine dipstick will become positive. So here the dipstick was strongly positive because there was myoglobinuria, but there was hardly any red cells. So this is another clue to diagnose myoglobinuria or hemoglobinuria, right? You have a profound, very positive dipstick blood, but when you look at the urine, there are no red cells. So why did this patient develop rhabdomyolysis suddenly? Any thoughts? Obviously, it's due to atorvastatin, but why should somebody with atorvastatin suddenly develop rhabdomyolysis? He would have been on this drug for a long time. Any thoughts?
Reduced excretion.
Erythromycin.
Erythromycin, yes. Why? How can erythromycin cause rhabdomyolysis?
It can inhibit cytochrome P450 liver.
Yes, that's right. So you know that cytochrome P450 is involved with metabolism of statins. So when you give erythromycin, it will inhibit the cytochrome P450, so that the any other drug which is metabolized by cytochrome P450 will be affected. The levels will go up. So statin levels will go up. So that is why the patient developed rhabdomyolysis. So it's a drug interaction. So you have to be. That's why you need to be careful when somebody is on statins. Especially when you are giving drugs which can inhibit the cytochrome P450 enzyme system, it might cause drug toxicity at atorvastatin, right? Okay, so that's that. So done that. So in fact, patient CPK came as more than 10,000. Urine myoglobin was positive, and the management is to stop the atorvastatin and also erythromycin, and then start and give aggressive hydration with 0.9% sodium chloride, and also you can give some furosemide to kind of get rid of, flush out the myoglobin. And also sometimes if the levels are very high, CPK levels, you sometimes alkalinize the urine with sodium bicarbonate, which will also help to remove myoglobin. Okay, so those are the two cases that I wanted to do. So have you got any questions before we move on to the nephrology pearls part? So probably we won't take the entire 2 hours. We can finish it before in probably in 1 hour's time. Any questions from these two cases? Okay, so if not, we'll move on to the next one, and you can even ask questions at the end of that. Okay, can you see the screen?
Yes, sir.
Okay, so right, case number one. So basically here what we are, these are also cases, but the objective here is different. Here, what we are more focused is on some important things that you might have to do during clinical management of patients that sometimes you might not do in actual setting, and that can lead to some serious serious problems if you miss certain things, little things. So some of these little things, so they are like pearls, you know, they are important, very valuable things that you might have to do, and if you miss them, then you end up in major catastrophes. So these are pitfalls. So pearls and pitfalls, that's why it's called that. So this is what we are going to highlight with the next few cases. Right. So you have a 68-year-old male referred to medical clinic for evaluation and management of diabetes. Diabetes diagnosed 20 years ago. He was also hypertensive. He had acute ST elevation MI 6 years ago and subsequently has had a bypass surgery. His medication included aspirin, metformin, atorvastatin, nifedipine, HCT, and prasucin. Right? Quite a lot of drugs. Most of them are for high blood pressure. On examination, so this patient has come for a routine clinic visit. Blood pressure was 160/100. Rest of the cardiovascular, respiratory, and abdominal examinations were unremarkable. So what's the problem here? The problem is the patient has got a bit of high pressure. On investigations, creatinine was 1.3, so it's slightly reduced. eGFR of 52, and albumin was traced on UFR, and HbA1c was 6.9, so that's quite okay. The patient was started on enalapril 5 mg daily because blood pressure was not controlled despite being on these drugs. And the only drug which was not given here is the ACE inhibitor or angiotensin receptor blocker class. So that is why this was started. And he was given lifestyle modifications on hypertension control. So what are those lifestyle modifications? Anybody? For hypertension management?
Diet control, doing physical activities.
Diet control. What do you mean by diet control?
Reducing amount of salt in food.
Yes, reduce salt intake. Any other lifestyle modifications?
Doing physical activities.
Yeah, so physical activities, again, exercise. You have to exercise for at least 30 minutes per day for 5 days a week. Yes, so that's one other thing. Any other lifestyle modifications?
Smoking cessation and alcohol cessation.
Yes, smoking cessation. So we don't know. I think probably maybe a smoker. We will have to. So those are the lifestyle modifications. So that is also being had been given. So the patient was started on a new antihypertensive, and then he was discharged. This is not discharged. Patient was sent home because it's an outpatient visit. Then patient is reviewed 3 months later. So generally we see patients in our clinics once in 3 months if they don't have major complication. Otherwise you see them monthly. So 3 months later, the patient comes again. Now the blood pressure is a bit better, 150 over 90, but still it's a bit elevated. However, his creatinine, which was found to be 1.3 earlier, has now gone up to 1.9. In fact, his EGFR has dropped from 52 to 34. Right? So, and the patient now this time was counseled on progressive nature of diabetic nephropathy. So the patient was told that creatinine has gone up. This was kind of picked up. And naturally, the most likely reason for this patient's kidney or renal impairment was thought to be as diabetic nephropathy. And as you know, diabetic nephropathy is a progressive disease, so it gradually gets worse over time. So that's what the medical officer told the patient. And so he has highlighted the importance of other measures to control the blood sugar, and also importance of controlling the blood pressure. So the patient first increased, enalapril dose was increased further to optimize the blood pressure. Then again, now the patient returns in 3 more months later. That's 6 months from the original visit. At this point, blood pressure now has got better. It's 120 over 80. However, now there's a small issue. The creatinine, which has now gone up to 3.6, EGFR has dropped to 16. So what you need to tell me is, what are the deficiencies in the management of this patient? How would you manage this patient at this stage? So those are the two things you have to answer. So can anybody tell me, what are the deficiencies in both? Are the same actually. So this is there is been an issue here. So that what is the issue, and how would you do it? How would you sort it out now? So those are the two questions that I want to ask you. So anybody wants to have a go? What has gone wrong here, and how would you sort it out? Hmm? Anybody?
So the serum creatinine and EGFR have changed drastically, and that would have been addressed.
Yes, so that is the thing. Now, why has this gone up? What is the reason? That is the issue here.
Maybe due to enalapril.
Yeah, so how could enalapril cause this problem? How
It's
does it?
possible
Yeah.
the patient has bilateral renal artery stenosis.
Yeah, so when you know that when people have bilateral renal artery stenosis, the blood flow to the kidney is dependent on renin, angiotensin, aldosterone mechanism. So this is what this patient had, bilateral renal artery stenosis. And so therefore, when you have reduced renal perfusion, you get activation of the renin, angiotensin, aldosterone system, and then it increases the blood pressure and tries to perfuse the kidneys. And also what the angiotensin 2 does is it constricts the efferent arteriole and tries to maintain the filtration pressure gradient. across the glomerulus. So you can read about this. And so this is how the glomerular filtration is maintained when there is a renal artery stenosis. So what the ACE inhibitor does is it dilates the efferent arteriole. So it blocks the action of angiotensin 2, either by reduced production of angiotensin 2 or by blocking the angiotensin 2 receptor. In this case, it was production of angiotensin 2. And it leads to this negation of this action of angiotensin 2 and causes reduction in GFR. And that is why the creatinine has gone up. So this is the mechanism. So that is the reason. So this patient has started on an ACE inhibitor, and that has caused a reduction, counteraction of this mechanism, renin-angiotensin-aldosterone mechanism, leading to reduction in GFR, and that's why the creatinine had gone up. Now, what were the deficiencies in the management? So obviously the doctors have failed to recognize this association. How could this have been avoided by the clinic doctor? What is the advice now you want to give for avoiding this in the future? Let's say you are the doctor who has caught this, and now you want to prevent this from happening again in the future. How would you advise? What is the recommendation? Anybody? This type of thing happening for patients. Any thoughts? Of course, one way is to not to give any ACE inhibitors or angiotensin receptor blockers to anybody. So then if somebody is having renal artery stenosis, there is no problem, because you don't have to worry, because none of them are getting ACE inhibitors and angiotensin receptor blockers. So is that the solution? What do you think? So that would be a one way of avoiding this type of problem in the future. So is there a problem in that, not giving angiotensin receptor blockers or ACE inhibitors for patients with hypertension and diabetes? You had a lecture on diabetic nephropathy, no? Diabetic kidney disease. You all are very silent. Are ACE inhibitors and ARB specifically indicated in patients with diabetic, whatever, kidney disease?
Yes, sir, because they have to reduce the nephropathy.
Yes, so that is one of the group of drugs that we generally advocate in people with diabetic nephropathy to reduce proteinuria, especially. So that's a very useful group of drugs. So therefore, you can't say I'm not going to give any person with diabetes or hypertension ACE inhibitors or angiotensin receptor blocker, because that means you are withholding a useful group of medications from this group of patients. So what is the solution? You have to give these drugs, but then how would you prevent this type of thing happening? What is the recommendation?
Following up the patient for this problem.
Following up. So this patient also was followed up. So you had to give.
Review the patient before 3 months, like about 1 to 2 weeks.
1 to 2 weeks swelling, you have to review the patient. Then what do you check? What do you check? Follow-up means you just ask the person to come and you have a look at the face. Huh?
Check serum creatinine.
Yeah, serum creatinine. So how do you say, like, this patient comes in, let's say 2 weeks, and you have a look at the patient's creatinine. So let's say same patient, instead of coming back in 3 months, now this patient came back in 3 months. No, when he came in 3 months time, the creatinine has gone up from 1.3 to 1.9. Now let's say you ask the same patient to come back in 2 weeks with a creatinine. So creatinine is now gone up from 1 point, let's say the same similar patient, and now it's gone up to 1.5 in 2 weeks. Now what will you do? Will you stop the enalapril? Or will you continue the enalapril? How would you decide?
We can suspect the renal artery stenosis and do imaging to confirm.
In that patient, 1.5.
Yes.
What is the normal? Isn't there normally a rise in creatinine when you start somebody with ACE inhibitor or angiotensin receptor blocker? Or in other words, don't you expect some rise in creatinine? You do. Normally the drug works. I told you how the drug works. It works by inhibiting the constrictive effect of angiotensin 2 and the efferent arteriole. That is how the drug works. So the drug works by reducing the GFR. So that actually how the drug works is by reducing the GFR, it reduces the strain on the glomerulus workload. So that's why in the long run, the kidney is protected when you're on ACE inhibitors or angiotensin receptor blockers. So the drug actually works through this mechanism. But what happens is in renal artery stenosis, they are so much dependent on this mechanism to maintain the GFR, which is dropped due to this problem of renal artery stenosis. So that is why then if you reduce the already low GFR, then you are going into renal impairment. So even for normal people who doesn't have renal artery stenosis, when you start the ACE inhibitor or ARB, there is a small rise in creatinine. So just a rise in creatinine is not an indication for renal artery stenosis or stopping the medication. So how do you decide whether somebody has got renal artery stenosis and the rise is due to renal artery stenosis? So obviously the rise should be more than just a little rise. So as I told you, if the creatinine was just 1.5 after 2 weeks from 1.3, I would not reduce or stop the enalapril because I think it's probably due to the natural action of the medication. But if it is gone up to a, let's say 1.3 to 2 like, or 1.7 or 8, then I know it's a significant rise. So in that situation, you have to think of renal artery stenosis. So generally the guideline is, the recommendation is that if the creatinine increases by more than 20% or 25%, then it is significant. Anything below that, you think that it's due to the physiological effects of the medication. So that's what we go by. So when you get down the patient at 2 weeks, no point in bringing the patient earlier than 2 weeks because the action is maximum at 2 weeks. And you should not delay it too much because then it's too late to do anything. So usually you bring down at 2 weeks or maximum in 1 month, and just to look at the creatinine to see whether there's a rise in creatinine, and if so, if it is less than 25% or more than 25%. If it is more than 25%, then you suspect that there could be underlying renal artery stenosis, and then you discontinue the ACE inhibitor or ARB. But if it's anything below that, the rise is less than that, then you could continue. But obviously you need to monitor them closely. So that is what could have been done in this patient. Bring the patient back in 2 weeks, look at the creatinine, see whether it's within the 25% rise, and then continue the drug. So that's how you should recommend using these medications in the clinic. Okay, so moving on to the next case. A 56-year-old female with type 2 diabetes presented with visible haematuria and reduced urine output for 3 days. She has no fever, dysuria or frequency. There's mild bilateral loin pain, and there's a wound in the left foot which had been there for 2 weeks. On examination, she was afebrile, mild periorbital and ankle edema, blood pressure 150 over 100, right? So there is some edema and there is high blood pressure. And when you look at the urine full report, there are pus cells and red cells and protein 1 plus, and serum creatinine is elevated. And in ultrasound scan, there are bilateral swollen kidneys and no obstruction, and ASOT is elevated to 400. So what's the diagnosis? Coming with haematuria and reduced urine output. Then there's hypertension, edema, red cells in urine, creatinine gone up, and also there had been a wound 2 weeks ago. Any thoughts? Yeah, so what the doctors thought was this was a post-streptococcal glomerulonephritis, because naturally the patient has had a wound preceding infection. There is features suggestive of acute nephritic syndrome, and ASOT is elevated. So clearly, I think the clinical diagnosis of post-streptococcal glomerulonephritis is quite reasonable. And patient was started on crystalline penicillin for the infection, and wound swab also returned Streptococcus pyogenes. So, however, by day 3 following the admission, the serum creatinine now had gone up to 4.5. It was 2.6 earlier. Anyway, they have sent some other investigations to find out whether any other causes for glomerulonephritis, such as A, NAP, and C ANCA, anti-GBM antibodies, complement levels. They have all returned normal. And renal biopsy was also arranged because of the suspicion of glomerulonephritis. But meanwhile, the urine culture, which was sent earlier, because sometimes you send urine cultures routinely, comes positive as E. coli. And then suddenly they have thought this could be due to patient was started on a broad spectrum antibiotic, and then urine improved, urine output improved, serum creatinine started to fall, and biopsy was not done. So all along, this was an acute pyelonephritis. Now, where did we go wrong in this patient? Sorry. Where did we go wrong? What was the pitfall and what was the, yeah. Anybody? Yeah, so essentially
patient.
yeah. Somebody wanted to talk. Go ahead.
The patient had bilateral loin pain.
Mm-hmm.
In glomerulonephritis, usually patient is not presented with loin pain.
Yes, that's right. So when you have patients, I mean this applies to all your patients you see. Sometimes we tend to ignore things which don't fit with our diagnosis. If most of the things fit with our diagnosis, now in this case, it looked like a very straightforward case of post-streptococcal glomerulonephritis because the patient has had typical features of nephritic syndrome, and there was a preceding infection. And when you looked at the examination, there was edema, there was high blood pressure. And when you looked at the urine, everything was in keeping with some kind of a glomerulonephritis. So, and when you look at the ASOT, that was also positive. So there was no doubt in our mind that this is a typical acute nephritic syndrome or post-streptococcal glomerulonephritis. But what you tend to ignore is some of the things which doesn't fit. Like, for example, presence of bilateral loin pain. So that is a bit unusual for just a post-streptococcal glomerulonephritis. So sometimes what happens is we tend to ignore some of the things which doesn't fit in with this diagnosis. And you are happy, you are comfortable with what you try to become comfortable with what you got. But the problem is then you may be missing on a other diagnosis which has similar clinical presentation. Now, as you know, this patient actually had acute pyelonephritis. Now, when you look at acute pyelonephritis and try to fit in all these things, they are also compatible. For example, haematuria can occur in urine tract infections, and reduced urine output in this case was not due to nephritic syndrome. It was due to acute kidney injury precipitated by the infection. Then patient didn't have fever, dysuria, and frequency. So that was that was against a urine infection. But you need to know that sometimes you can have infections, serious infections, without any symptoms. And loin pain, of course, is there. So that was in keeping with our clinical diagnosis. And wounds are so common in diabetic patients. That doesn't mean that everybody who has a wound has got nephritic syndrome. And then you might argue that how can somebody with pyelonephritis get periorbital edema and ankle edema? So what is the explanation for that? Anybody? Yeah, what you need to understand is this patient could be having underlying diabetic nephropathy, because these patients are probably they don't need to have one diagnosis. They could be having underlying other problems also. So when you know somebody has diabetic nephropathy, proteinuria, and they may be having some degree of ankle edema, periorbital edema, and then blood pressure could be high also because of that. So therefore, all along this could be, and when you look at the UFR, you see that that there are quite a significant pus cells in this patient's urine, and so all in all, this other diagnosis also fits. It's just that we didn't think of it because we were not comfortable with that diagnosis, and we felt happier with the post-streptococcal glomerulonephritis. But what you need to understand is basic things have to be done in any case, like doing a urine culture. So that's what saved the day for this particular patient. So if you had missed this diagnosis, then eventually what will happen is you would have treated, if the patient was not improving, you might even have considered giving immunosuppression. And that would have been catastrophic in this patient, because with underlying infection, with immunosuppression, her infection would have flared up further, and she might even have died. She has died. So that's the thing that you need to keep in mind. Some of the little things. So the whole idea was of these particular two cases, nephrology pearls, was to highlight that in the first case, the fact that you need to understand some importance of following up a patient. within a short period to avoid a catastrophe. Again, the patient's kidney function deteriorates so rapidly after that because you didn't evaluate this patient for possible renal artery stenosis. And then the second case, you went out with this diagnosis of straightforward diagnosis of post-streptococcal glomerulonephritis without thinking of other alternative possibilities and not trying to explain all the symptoms that the patient had. So that this highlights that, you know, the importance of not diving full length into a kind of a you know, diagnosis or a you know, patient care, but at the same time you have to think of laterally, think of other things that could mimic you know, problems that can be similar. So these are the things that I wanted to highlight with these two cases in this presentation. So now I think we have finished the two cases and both the case history session as well as the Pearl session. So I will give you, and this is the last lecture of the module, if I'm not mistaken. So this means that you have completed your module. So if you have any questions, any clarifications you want to bring in, this is the time. I mean, after this, when are you having the exam?
We haven't been informed about that, sir.
Not informed, no? So so it will happen quite soon. So so if you have any questions, you should ask now. Doesn't have to be from this lecture. You can even any other question you have in relation to nephrology, you can ask me. Or even you can send in through the chat if you are shy to ask. No questions. You have understood everything crystal clear. Huh? Very good. Or you haven't understood anything, so there's no need, no point in asking any question. Which one is it? Okay, in that case, we'll stop there. So all the best for the exam, right? So usually there won't be any issues in nephrology, so people do quite well. Okay, we'll stop there. Good luck.
Thank you, sir.